Jude, Lauren, Ann for inviting me to discuss the perspective from the world strategies that have been developed over the last few years for elimination of hepatitis C down through the recent recommendations from the U.S. task force to where we are here in Oregon, throwing in a bit of perspective from a clinician standpoint in terms of how hepatitis C affects the population and the individuals. I started dealing with Hep C about the time we started a transplant program for liver disease at OHSU back in the mid-'80s. And at that time it was non-A, non-B hepatitis, and we were treating patients with interferon before we even knew what the virus was. And we were getting response rates of somewhere between 5 and 10% clearance using toxic medications for 6 to 12 months. So we've come a long way. In terms of world burden of hepatitis C, it's estimated that there are about 1.4 million deaths worldwide yearly. Almost half of this is due to Hep C, the rest mostly hepatitis B. There's 71 million deaths annually are infected with hepatitis C, and these cases are increasing. Over the last 10 or 15 years, with the World Health Organization focusing on major infectious diseases, there have been significant drops in HIV, about 40%. In deaths, there's been about a 20% drop in malaria deaths, 10% drop in TB deaths. This is while deaths from viral hepatitis have been rising. It's estimated that there are about 1.7 million new cases of Hep C in the world each year right now, and there's probably about 1.2 million cases disappearing, most of those through death and about a third of them from effective treatment. It's estimated that probably about 5% of the world hepatitis C burden has been treated. This is a schematic of viral hepatitis occurrence around the world. The size of those pie diagrams is proportionate to the number of deaths by region in the world as of 2017, according to the World Health Organization. The dark green is Hep B, the lighter blue-green is Hep C. So you can see Asia, South Asia, West Pacific has a lot of viral hepatitis. Most of it's B, but there's a lot of Hep C there. And the highest incidence in the population around the world at this point is in the Middle East, the Eastern Mediterranean, Eastern Europe, and Asia. They have incidence about 5 to 10 times what we have here in the U.S. However, in the U.S., most of our viral hepatitis deaths are from hepatitis C. And about a third of those deaths are from hepatoma, hepatocellular carcinoma. About 2/3 are related to advanced liver disease. It's believed that the epidemic of Hep C around the world really flared after World War II. And there was a lot of transmission within healthcare systems with contaminated needles, as well as more recently intravenous drug use. This has resulted in a cohort effect. We've seen great drops in the transmission of Hep C, particularly in the West, since practices in the blood transfusion community, as well as the HIV epidemic in the 80s that changed practices among IV drug users. At that time, there were marked drops in new cases of Hep C in the West. And that's how we resulted in a group born between 1945 and 1965 that account for about 75% of Hep C cases in the U.S. That age distribution cohort varies a bit around the world, but depending on when the exposures occurred, but it's similar to that in Japan and Europe. This schematic here demonstrates that while the peak prevalence has been peaking and we're hoping to see it turn down with therapy in the near future, although as I just pointed out, it's still rising. Even if we treat it fairly aggressively, we're not going to see stabilization of advanced liver disease until probably 2020 or 2025. Back in the 90s, when we did a cross-section of the population, about 5 or maybe 10% of our patients had cirrhosis. As this group of infected patients gets older, we find in a survey in one of the big healthcare insurance groups here in Portland that about 35% of their Hep C patients, we surveyed about 2,300, 35% had cirrhosis and or hepatocellular carcinoma. It's estimated that by 2030 in the U.S., probably 50% of the patients we have with Hep C will have cirrhosis. So this is a moving target as the disease matures in the population. See if I can get this thing to advance. Okay, the next slide, please. Oops. In terms of individual patients, we see a progression of infection over time that's highly variable. Roughly about 10% of the patients with Hep C per year progress from very mild injury, which we call F1 scarring, through cirrhosis. But there's some patients that can progress to advanced liver disease in a matter of 12 to 15 years, and others that never go on to advanced liver disease despite several decades of infection. Once patients get to these advanced scarring stages, which again is probably 35 to 50% of what we're seeing these days, there's risk of developing decompensation and liver failure and liver cancer 3 to 4% per year. We've also learned when we clear hepatitis C from these patients, these risks go way down, 70 to 80%, but there's still a lingering risk about 1.5 or 2% per year of developing liver cancer. So it's best to avoid these stages by treating earlier on. About a third of untreated patients will have their life shortened by these end-stage liver disease complications. We've talked about the lifelong risk of advanced scarring, even when the virus is gone, from developing cancer. We also know that in the U.S., about 75% of the new cases are associated with intravenous drug use. Most of these patients are relatively early on in their infection, and when we choose to treat only the more advanced cases, we are not treating the patients that are transmitting most of the disease. Next slide. Thank you. This just flips through quickly the various stages of liver scarring that we see. Let's go on to the next slide. Moving on to treatment, we've had a major revolution from the old interferon days when we could cure 10% with a lot of side effects to a smorgasbord of antivirals that are now available to treat patients with 95% cure rates. These are generally drugs we use for 2 to 3 months. They have few side effects. We have to stop only 1 or 2% of patients because of side effects. We find our adherence is extremely good. Even in the Oregon Health Plan population, we've had 1 patient out of 65 last year that didn't complete their course of medication, and we had response rates of 94%. The wholesale cost has gone down markedly. As we all know, when the first combination drugs became available about 3 years ago, the price was up around $80,000, $84,000 per treatment course. With the newer drugs that have been approved in recent months, it's down to the 26% for wholesale cost, and so that represents about a 75% price reduction. Several of these drugs are pangenotypic. They'll treat all the subtypes. They're also very well tolerated in patients with advanced liver disease, cirrhosis. Because these drugs are easy to use with low side effect profile and are well tolerated in cirrhotic patients that are not in liver failure, primary care providers can also treat with these drugs very effectively. Next slide. In terms of effective treatment on natural history of the disease, this lower slide is from experience over a period from about 2005 to 2012 with interferon-based therapies, showing that patients that clear the virus have a much lower rate of cancer development than patients that don't or haven't been treated, and the same with liver failure. So there's about a 70 to 75% reduction in these complications. The upper slide is from a publication from just last month looking at direct-acting antivirals, the drugs we're using now, reducing liver cancer risk by 73% in the VA population. This is about 22,000 patients that were followed. These drugs have been developed very rapidly, and they've been developed in such a fashion that most of the trials have been done comparing to either historic controls rather than the old standard of therapy, which was interferon. It's been impractical to perform those trials because patients will not take those drugs because they don't work and there's very high side effect ratios. Surrogate markers of clearing the virus have been used as target for those trials that typically go over a matter of 12 to 18 months. Then drugs are applied for approval, and typically it's based on that information. These trials are not designed to look at end-stage liver disease development, liver cancer, which, as we saw, evolves over many years to decades. There was a recent Cochrane collaboration that reviewed efficacy of these drugs that concluded that there's no evidence that they're effective in these end-stage or these endpoints of death and end-stage liver disease. But you can see some of the reasons for that to occur. They weren't practical to compare against the standard of care, and the length of the trials don't permit those endpoints. Next slide. So the World Health Organization set a goal in 2017 to reduce the presence of hepatitis C infections by 90% by 2030 and reduce mortality related to hepatitis C by 65%. And they recommended that governments need guidance on how to achieve these targets with limited resources. Next slide. This is the strategic targets that were set out by the World Health Association through the Global Health Sector Strategy that was announced in 2016 for treatment of viral hepatitis. And they defined 5 specific directions. First is defining who and where needs to get treated, getting the information on where the disease is, in what groups, and who has the disease, the epidemiology. The second sector to attack was interventions. This is basically treating patients that have it and intervening transmission. The third is delivery of care, expanding the number of people that are treating the drugs, and identifying groups that need to be treating and getting in and effectively diagnosing and treating. The fourth section is financing, coming up with effective ways to get these expensive meds at lower prices, creative negotiating, and some other ideas. And much of what we've seen in the last few years has been market competition that's caused the drug cost to drop. The fifth area is future directions, which we'll talk about in terms of research to make the next steps for diagnosis and treatment. Next slide. So approach to disease elimination typically is aimed at defining or targeting specific high-risk populations and particular areas of the geography to try and eliminate primarily. And this has been the pattern for many of the approaches to infectious diseases around the world. Hep C strategies, as I suggested, are targeted on treatment and transmission. For low-income groups, low-income countries, they've been able to negotiate very low costs for these medications. It's estimated that some of these these direct-acting drugs can be manufactured for less than $100 to $200 for a whole treatment course. Many of these countries have been licensed to manufacture their own drugs. One example is Egypt, that has a very high rate of Hep C infection, largely because of medical practices back in the 50s to treat schistosomiasis, a lot of shots with non-sterile needles back then. They've treated about over 300,000 individuals per year in recent years. They believe they've cured 1 million people in Egypt in the last few years with direct-acting drugs. And they estimate the cost not only for drugs but for the whole treatment process is around $350 or less per treatment course. The challenge in high-income countries is obviously more challenging. The drugs are not as cheap and not licensed at these lower levels. Despite that, several countries have made a commitment to elimination of Hep C France committed in 2016 to eliminate Hep C by 2025, as have several other countries. Microelimination targeting is the approach for many countries. Subpopulations such as hemophiliacs were initially targeted in Ireland, and they're largely eliminating Hep C in that population. We know in the U.S. we're targeting the 75% of individuals with Hep C in the birth cohort of the baby boomers, and we're also targeting specific settings such as addiction and treatment centers, prisons, and that sort of thing. So this is the concept of micro-targeting. Next slide. And this just reminds us of the continuum of care from identifying patients that are infected by antibody testing, confirming infection by RNA, linking these patients to care, providing an assessment of the severity of liver disease, getting patients on treatment, and then following through until cure. Trying to establish how much work is to be done and how we're doing is based on getting information of where we are in each of these steps. It's estimated in the U.S. that somewhere between 50 and 75% of Hep C patients are undiagnosed. The number is probably 80% around the world. Testing has gone off from there. Linkage to care is a little bit tough to get our fingers on, but as we discuss things today, we can think about how we might get this information better pinned down. We have at the state level reporting to the health division on diagnostic tests to figure out how many patients are testing positive. This could conceivably be used to look at RNA testing and see who's had positive tests that have gone negative as treatment. We can use electronic databases to look at numbers of prescriptions to figure out how many patients are getting treated. And similarly, hopefully be able to figure out who's been cured by following RNA testing reports through the labs. Next slide. So based on these recommendations at the world level, the National Academy of Sciences, Engineering, and Medicine put out their Phase 2 report last May, which paralleled a lot of these recommendations from the World Health Organization. And they specifically address strategies at each of these specific points, including information. They pointed out there's a lot of underreporting in terms of linking etiology of end-stage liver disease and liver cancer to a specific virus, not often noted on death certificates. Their need for automated systems to track prevalence, linkage to care, treatment, and outcomes. They also pointed out that intervention such as limiting exposure needs a lot more emphasis on needle exchange and opiate substitution therapy, and recommended that these approaches be ramped up significantly. They also recommended that we reduce the delay in treatment for all patients with hepatitis C to minimize progression to advanced liver disease, as we discussed, and specifically recommended that DAAs be offered to all patients with hepatitis C based on medical necessity. Next slide. In terms of service delivery, it is recommended that the AASLD and the infectious disease societies emphasize training primary care providers and extenders to treat patients with hepatitis C around the country, and to specifically focus on marginalized individuals that aren't even in the healthcare system at this time, and perhaps suggested a parallel Ryan White type act that was developed for HIV would be appropriate for viral hepatitis. At this point, the expenditures on viral hepatitis is less than 1/10 of that on HIV on a federal basis. Financing elimination. One of the very exciting ideas is that of licensing through the federal government specific antivirals, licensure to be bought by the government, or perhaps $2 billion, and having the states pay the balance of about $140 million. They compared this, with this approach, they thought they could eliminate about 770,000 patients that are marginalized or in the prisons at the cost of about less than $2.5 billion. As opposed to the approach we're taking now over the next 10 years, it would treat about a quarter of that many patients at $10 billion. So this is one way to get the cost down to about $2,000 per treatment course. Next slide. New research, specifically in Hep C, that recommended more emphasis on vaccine development, rapid diagnostics at point of care, such as RNA testing that can be done at point of care, treatments for fibrosis for those with more advanced liver disease, and then more research on how to reduce stigma on patients with injecting drug use and how to prevent transmission in that setting. And this will require the sort of cooperative organization we're trying to target here today. Next slide. Hep C is rising in Oregon. We talked about it dropping through the 80s and 90s, but with the increase in IV drug use, often secondary to the proliferation of non-prescription opioids, we've seen a rise, particularly in young people, as noted in purple, 20 to 29-year-olds with Hep C. There have been specific outbreaks, such as the one in southern Indiana, 200 new cases of HIV, 600 new cases of Hep C in a community that was undertreated, or that was underserved with people that knew how to treat the disease, and it was targeted, or it was predicated on a very high level of prescription opioid use transitioning to heroin. And I know we have several counties in Oregon that are among the highest in the country in terms of recent prescription use of opioids that put us at risk. Next slide. So there's good evidence for using opiate substitution of reducing Hep C transmission by about 50% and a 70% reduction when we combine opiate substitution with needle exchange programs. This is another Cochrane analysis. Modeling shows that using treatment plus these risk reduction approaches are the most efficient way. You can use less drug treatment if you have more needle exchange and opiate substitution. Next slide. I've got a slide here from Australia, which has essentially had 100% penetration in their needle exchange programs. Next slide, please. And in 2016, they got licensure for cheap treatment with direct-acting antivirals, and they were able to treat over 20% of their injection drug users, and they were able to show that year that they were able to drop the RNA prevalence in that population by about a quarter. So this is with their average needle exchange was 300 per IV drug user, which is the target for 2030 around the world. They're already there. And they only had to treat 20% of their people to significantly drop the pool. So this just gives you an idea of what can be done. Next slide. So this is where we are with all the work that the committee that's been working over the last year has put us for where we're headed in Oregon. And you've got this on your table. I won't go into it in detail. Next slide. So this is my back of the envelope of where we are and where we might go. We estimate 80 to 100,000 patients infected in Oregon. Paul said about 90,000. We believe that perhaps half of those are diagnosed. And trying to get an idea of how many we're treating right now is a little hard to do. We think we're treating 200 or 300 a year. I heard that Kaiser's treating about 400 a year. OHSU is treating 200 or 300 or 400 a year. So we may be treating 1,000 a year or more around the state. We may have treated 5,000 or 10,000, but you can see we've still got a long way to go. And to get there, not only do we need a better job of figuring out who has the disease and linking them to care, but increasing our capacity through many of the programs you'll be hearing about and that many of you are participating in. Next slide. So specifically, interventions that I think we should look at. Well, first of all, information. We need to get systems that allow us to track screening, treatment, outcomes. We need OHP to use the information that they're gaining from treaters. When we treat OHP now, we send them the results and who's got a clearance. So we know, at least in that group, which is probably about a quarter of the Hep C population, the data is there and it should be transparently available to know how we're doing. Needle exchange, we need DAAs for all patients. We need to train primary care, and we need to particularly focus on marginalized individuals, and we'll learn more about the efforts in the prison systems. Finance, we've dropped the cost by 75%. Maybe if the federal government can buy a licensure, we can get it down to attempt that. Wishful thinking. Thank you.